If your memory has changed quickly after 60, do not assume dementia is the only explanation. Certain medicines can slow attention, block memory signals, disturb sleep, lower blood pressure, or build up in the body until you seem like a different person. A familiar name disappears. You lose the thread halfway through a sentence. You wake confused, unsteady, or unsure what happened the night before. These medicines can also be necessary and beneficial. Do not stop, skip, reduce, increase, replace, or reschedule any prescription on your own. The right response is a careful review with the doctor or pharmacist managing your care, especially when confusion began after a new drug, a higher dose, an illness, dehydration, or a hospital stay. I'm Dr. Lee, and for this video, we reviewed current medication safety guidance for older adults. I will show you 9 medication traps that can imitate rapid cognitive decline, what each one does inside the brain, and the exact questions to take to your next appointment. Number 3 becomes especially dangerous when kidney function changes. But number 1 is the trap families miss most because no single bottle looks responsible. Number 9 is the nighttime antihistamine hiding inside many allergy and PM products. Diphenhydramine, known as Benadryl, and doxylamine, found in some nighttime sleep aids, are easy to buy without a prescription. That makes them feel harmless. But both can strongly block acetylcholine, a chemical your brain uses for attention, alertness, and forming new memories. After 60, the body usually clears sedating medicines more slowly. A pill taken at bedtime can still be affecting balance, reaction time, and thinking the next morning. You may call it poor sleep or an aging moment. In reality, your brain may still be under the drug's influence. A common pattern looks like this. Someone starts taking a PM product for occasional insomnia. Within weeks, it becomes nightly. Then the family notices repeated questions, a slower morning routine, and unusual uncertainty while driving. Nobody checks the label because the product came from a supermarket shelf. The American Geriatric Society lists first-generation antihistamines as medications generally best avoided in older adults because of confusion, dry mouth, constipation, and other anticholinergic effects. FDA labeling also warns that older adults are more likely to experience dizziness, sedation, and low blood pressure from diphenhydramine. The practical step is simple. Check every allergy, cold, pain, and sleep product for diphenhydramine or doxylamine. Ask whether a less sedating allergy treatment, a different sleep strategy, or treatment for the real cause of insomnia would be safer for you. Look for a cluster, not only forgetfulness. Dry mouth, constipation, blurred vision, trouble urinating, unusual daytime sleepiness, and confusion can point toward an anticholinergic effect. Write down when those symptoms appear. That pattern gives your clinician far more useful evidence than simply saying, "My memory feels worse." If this is already helping, you connect a symptom to a bottle, subscribe to Age Clarity Health. You may also write your medication, memory concern, or health question in the comments. I personally read the comments and respond whenever possible. Number 8 is the bladder medicine that can calm urgency while clouding the brain. Oxybutynin is prescribed for overactive bladder. Related drugs include tolterodine and sulfonylurea. These medicines reduce bladder contractions by blocking muscarinic receptors. The problem is that some of them also enter the brain and interfere with the same acetylcholine system needed for clear thought. This matters because bladder symptoms already steal confidence. You may avoid shopping, long drives, church, or visiting family because you fear not reaching a bathroom. A medicine that gives you freedom can feel impossible to question, even when you begin losing words or feeling mentally slower. Oxybutynin has one of the clearest cognitive warning signals within this group. Research comparing anticholinergic medicines has repeatedly found stronger cognitive effects with oxybutynin than with several other bladder treatments. Long-term observational studies also associate some bladder antimuscarinics with higher dementia risk, although those studies cannot prove the medicine caused every case. Do not trade bladder control for fear. Ask the prescriber whether the dose is still necessary, whether bladder training or pelvic floor treatment could reduce reliance on medication, or whether a medicine using a different pathway, such as mirabegron or Vibegron, is appropriate. Those options have their own precautions. Mirabegron, for example, can affect blood pressure. The choice must be individualized. The most revealing question is not, is this drug bad? It is, did my thinking change after I started it, increased it, or added another anticholinergic medicine? Timing can expose what age alone cannot explain. Number 7 is an older antidepressant often prescribed for problems that have nothing to do with depression. Amitriptyline may be used for nerve pain, migraine prevention, sleep, or mood. It can be effective. It can also be strongly anticholinergic, sedating, and capable of lowering blood pressure when you stand. That combination creates a dangerous illusion. You feel tired, slower, forgetful, and unsteady. You stop cooking complicated meals because following several steps feels exhausting. You avoid the stairs because you become lightheaded. Family members see withdrawal and poor concentration and begin whispering about dementia. Inside the body, several effects are arriving at once. Acetylcholine is blocked. Sedation reduces alertness. Dry mouth may reduce fluid intake, while constipation can worsen discomfort and confusion. A blood pressure drop can briefly reduce blood flow to the brain when you stand. None of these proves permanent dementia, but together they can make daily thinking look dramatically worse. A large prospective study followed more than 3,400 adults aged 65 and older. The group with the heaviest cumulative exposure to strong anticholinergic medicines had a 54% higher rate of dementia than non-users. That was an association, not proof that one medicine caused dementia, but it is strong enough to justify regular review. If you take amitriptyline, ask why it was originally started and whether that reason still exists. The best alternative depends on whether the target is nerve pain, migraine, sleep, or depression. Do not accept a random replacement from an online list. Ask for an option that treats your actual condition with less anticholinergic and sedative burden. Number 6 is paroxetine, commonly known as Paxil. Paroxetine belongs to the SSRI antidepressant family, but it is different from most medicines in that family because it has meaningful anticholinergic activity. It can also cause sedation, dizziness, and low sodium, especially in older adults or people taking diuretics. Low sodium deserves attention because it can produce headache, weakness, unsteadiness, confusion, and in severe cases, seizures. The change may appear after starting treatment, increasing the dose, becoming ill, drinking excessive plain water, or adding another medicine that affects sodium. Imagine a 72-year-old who has taken paroxetine for years without obvious trouble. A diuretic is added for blood pressure. A week of poor appetite follows a stomach illness. Suddenly, she is weak, confused, and repeating herself. The family fears rapid dementia, but the real problem could be a medication interaction combined with low sodium and dehydration. That situation needs prompt medical assessment, not a home experiment. The American Geriatric Society identifies paroxetine as strongly anticholinergic and generally less suitable for many older adults when better tolerated choices are available. FDA labeling also warns that paroxetine-related low sodium can cause memory impairment, confusion, weakness, and unsteadiness. That does not mean everyone taking it must change. It means the benefit, dose, withdrawal risk, and available alternatives deserve a deliberate review. Never stop paroxetine suddenly. Withdrawal can cause dizziness, anxiety, sleep disruption, flu-like sensations, and electric shock feelings. Ask whether your sodium should be checked, whether the current dose remains necessary, and whether a slow supervised transition is appropriate. Number 5 is the benzodiazepine family. Lorazepam, known as Ativan, alprazolam, known as Xanax, clonazepam, known as Klonopin, and diazepam, known as Valium, can bring real relief from severe anxiety, panic, seizures, or acute distress. But in older adults, they can also impair new memory formation, slow reaction time, worsen balance, and trigger delirium. The memory effect can be frighteningly specific. You may function during a conversation but fail to store it properly. The next day, other people insist you agreed to something you cannot remember. You may repeat a phone call, take a second dose, or accuse someone of moving an item you placed yourself. The 2023 American Geriatric Society guidance states that all benzodiazepines increase the risk of cognitive impairment, delirium, falls, fractures, and motor vehicle crashes in older adults. Long-acting drugs can be especially troublesome, but a short-acting name is not automatically safe. Older bodies are more sensitive to the entire class. The exit from these medicines also requires respect. Abrupt withdrawal after regular use can cause severe anxiety, agitation, hallucinations, seizures, and other dangerous reactions. A safe taper may take weeks or months and must be tailored to the person. Before we continue, notice the pattern. The first 5 traps reach the brain through different doors, but several converge on the same result. Less alertness, weaker memory formation, lower blood pressure, or too little acetylcholine. When 2 of these effects overlap, the decline can look far more serious than either medicine alone. This is also why a normal brain scan does not automatically end the investigation. A scan can help rule out certain emergencies and structural problems, but it cannot show that yesterday's dose was too strong, that sodium has fallen, or that 3 sedatives are overlapping. The medication timeline, blood tests, vital signs, sleep pattern, and family observations can reveal what an image cannot. Subscribe to Age Clarity Health if you want clear, protective health information designed for life after 60. Tell me in the comments whether your concern is memory, sleep, anxiety, bladder control, pain, or balance. I personally review the comments and reply whenever I can. Number 4 is the group often called the Z-drug sleep medicines. Zolpidem, known as Ambien, Ecopiclone, known as Lunesta, and Zaloplan, known as Sonata, are not benzodiazepines, but they act on a similar calming system in the brain. Many people believe they are gentler because the name is different. For an older brain, the practical effects can still include next-day sedation, memory gaps, poor coordination, and confusion. The timing creates the trap. A person takes Zolpidem late, wakes after only 4 or 5 hours, then drives to an early appointment. The pill has not finished its work. The person appears slow, distracted, and unsafe, yet may have no idea how impaired they are. These medicines can also cause complex sleep behaviors. People have prepared food, walked outside, made phone calls, or driven while not fully awake, then remembered little or nothing. The FDA requires a boxed warning for serious injuries from complex sleep behaviors with Zolpidem, Ecopiclone, and Zaloplan. Ask 3 questions. Am I taking it early enough to allow the full required sleep period? Am I combining it with alcohol, opioids, antihistamines, or anxiety medicines? And has the original reason for insomnia ever been investigated? Pain, sleep apnea, restless legs, depression, nighttime urination, reflux, and poorly timed caffeine can all keep sleep broken. Adding stronger sedation without treating the cause can leave you unconscious for part of the night, but still unrefreshed and mentally dull the next day. Do not double a dose because the first one did not work. Do not take it after waking in the middle of the night unless that exact product and timing were prescribed. And if anyone reports nighttime behavior you cannot remember, contact the prescriber promptly. Number 3 is opioid pain medicine, especially when the dose no longer matches the body clearing it. Hydrocodone, oxycodone, morphine, fentanyl, codeine, and tramadol can be essential after surgery, serious injury, or for certain severe pain conditions. The danger begins when sedation is mistaken for peacefulness, or when drug accumulation is mistaken for dementia. Kidney and liver function often change with age, illness, dehydration, or weight loss. A dose tolerated last year can become too strong after a hospital stay or kidney decline. The result may be unusual sleepiness, slowed breathing, small pupils, hallucinations, confusion, or repeated drifting in and out of conversation. Tramadol deserves special caution because it has opioid effects and also changes serotonin and norepinephrine. It can interact with antidepressants, contribute to seizures, and produce confusion. Mepridine is especially problematic in older adults because a metabolite can accumulate and affect the nervous system, which is why geriatric guidance recommends avoiding it. The combination matters even more than the name on the bottle. FDA boxed warnings explain that opioids combined with benzodiazepines or other central nervous system depressants can cause profound sedation, respiratory depression, coma, and death. Alcohol adds another depressant effect. If a person taking an opioid is difficult to wake, breathing slowly, making choking or gurgling sounds, or has blue or gray lips, call 911 immediately and use naloxone if available. That is not normal sleep, and it is not a moment to wait for the next appointment. For non-emergency concerns, bring the exact bottles to a medication review. Ask whether the dose still matches kidney and liver function, whether the schedule can be simplified, whether naloxone should be kept at home, and whether non-opioid pain treatments could reduce the total dose without abandoning pain control. Number two is antipsychotic medication used without a clearly documented reason or review plan. Quetiapine, known as Seroquel, risperidone, known as Risperdal, and olanzapine, known as Zyprexa, are important treatments for conditions such as schizophrenia and bipolar disorder. In some situations, certain antipsychotics may also be used for severe agitation or psychosis when a person with dementia poses a danger and safer approaches have failed. The trap is casual use for ordinary sleeplessness, restlessness, or caregiver convenience. These are powerful brain medicines. They can cause heavy sedation, slowed movement, stiffness, dizziness, blood pressure drops, and reduced emotional expression. To a family, the person can seem to disappear behind a blank face. FDA labeling carries a boxed warning that older adults with dementia-related psychosis treated with antipsychotics have an increased risk of death. Several also carry warnings about stroke risk in this population. They are not approved simply to make an older person easier to manage. Before blaming behavior on dementia, clinicians often look for pain, constipation, urinary retention, infection, dehydration, medication withdrawal, sleep disruption, hearing loss, vision problems, or an overstimulating environment. A person who cannot explain severe pain may become agitated. Sedating that person without finding the pain can silence the warning while the cause gets worse. Ask the prescriber 4 direct questions. What exact symptom is this treating? What evidence shows it is helping? What side effects are being monitored? And when will the need and dose be reassessed? Do not stop an antipsychotic suddenly without guidance, but do not allow it to continue indefinitely without a clear purpose. The goal is not maximum quiet. The goal is the safest possible level of comfort, function, personality, and dignity. Now we reach number 1, the combined anticholinergic and sedative burden nobody has added up. This is the most important trap because each individual prescription can look reasonable. The allergy pill came from the drugstore. The bladder pill came from a urologist. The nerve pain medicine came from a different clinic. The anxiety medicine was started after a bereavement. The opioid was added after surgery. No single prescriber sees the complete picture. CDC data show that 67.7% of Americans aged 65 and older were taking at least 3 prescription medicines in the 2017 March 2020 survey period. That does not mean 3 medicines are automatically too many. It means interactions and overlapping effects are common enough that regular review matters. Think of your brain as a room with several dimmer switches. One medicine lowers alertness. Another blocks acetylcholine. Another drops blood pressure. Another builds up because the kidneys are clearing it slowly. A 5th fragments sleep. Each change seems small, but together the room becomes dark. A typical family notices the decline after one final addition. An older man has managed 5 medicines for years. After back surgery, he receives an opioid and begins using diphenhydramine because pain keeps him awake. Within days, he is hallucinating, missing doses, and trying to leave the house at night. The family believes surgery accelerated dementia. The more immediate explanation may be delirium caused by pain, sleep loss, constipation, dehydration, and stacked sedating medicines. Delirium is sudden, fluctuating confusion. It often develops over hours or days, unlike the slower pattern typical of many dementias. A person may be clear in the morning, frightened and disoriented at sunset, then unusually sleepy later. Medication effects are one possible cause, but infection, low oxygen, low blood sugar, dehydration, electrolyte problems, and organ failure can also trigger it. Sudden confusion is urgent. Call for immediate medical help when it comes with facial drooping, one-sided weakness, severe headache, chest pain, breathing trouble, fever, a fall with head injury, a seizure, inability to wake, or dangerously low blood sugar. Even without those signs, a new rapid mental change deserves same-day medical assessment. The hopeful truth is that medication-related cognitive symptoms can improve when the cause is found and corrected. Improvement may happen quickly when the problem is an excessive dose or acute interaction. It may take longer when sleep, dehydration, pain, illness, and several medicines are involved. No honest doctor can promise full reversal, but this is one of the most important treatable possibilities to investigate. The review should also protect the condition each medicine was treating. If anxiety returns, pain becomes uncontrolled, bladder urgency worsens, or sleep collapses, the plan has failed even if one side effect improves. Good medication care is not about removing the largest number of pills. It is about finding the smallest effective burden that still protects your health and daily function. Bring someone who knows your usual behavior when possible. A spouse, adult child, or close friend may remember that the confusion began 3 days after a dose increase, while you only remember feeling unwell. They can also help confirm whether alertness, conversation, walking, and independence improve after a supervised change. Here is the protocol to remember. First, build one complete medication list. Include every prescription, vitamin, supplement, pain reliever, allergy product, sleep aid, cream, patch, inhaler, and PM medicine. Write the dose, time taken, reason, prescriber, and date it was started or changed. Second, map the symptoms against the timeline. Record when confusion, repeated questions, dizziness, hallucinations, falls, daytime sleepiness, or memory gaps began. Note illnesses, dehydration, weight loss, hospital stays, and changes in kidney or liver tests. Third, schedule a structured medication review with a pharmacist or prescriber. Ask specifically about anticholinergic burden, sedative burden, duplicate treatments, drug interactions, kidney dosing, low sodium, low blood pressure, and whether every medicine still has a current purpose. Fourth, change only one thing at a time under professional guidance whenever possible. That makes it easier to identify what helps, what worsens symptoms, and what must be tapered slowly. One forgotten name does not prove dementia. One difficult morning does not mean your independence is disappearing. But a rapid pattern, especially after a medication change, should never be dismissed as just getting old. Recognizing it early can protect your memory, your balance, your driving, your confidence, and your ability to remain safely in your own home. Subscribe to Age Clarity Health and share in the comments which medication question you plan to take to your doctor or pharmacist. The next video will show you 7 warning signs that memory loss is not normal aging and when the pattern needs urgent medical attention. Protecting your future sometimes begins with one careful question about what you took today.